Hi, everyone, and welcome. This is the first of many opportunities to learn about managed care and what it means to you and our system of support. This forum today is meant to introduce the concept of managed care to people who are not familiar with it. Today, we have many different levels of understanding in this room. And for those of you who are more familiar with the concept of managed care, we may not get the opportunity to address all of your questions, but we will be getting the answers that you need over time as the process develops. There are many steps that have been taken and many more that still need to be taken in this process. So I want to make sure that folks understand that we don't have all of the answers yet. Our plan is to, through this process, open the doors of communication with all of you and make sure that we understand the questions that you have and get a greater understanding of what matters most to you when it comes to the services you receive. Today, we will be presenting a few slides which we will hope that explain what managed care is and what it means to you, and then we'll be answering a few questions that have been gathered from many of you in advance through your local advocacy organizations. Any questions, as I had indicated before, that we do not get to or that we don't get the opportunity to ask can be shared with us by an email following this forum, and there will be information included in these slides about how to reach out to us. And with that, we'll go ahead and begin the presentation. The systems of support for people with developmental disabilities has evolved over the years from an institution-based system to a community-based support system based on meeting the needs of each person. This evolution was brought about by the people that we support, their family members, providers, and our staff all working together toward a common goal. That goal is to help people with developmental disabilities live richer, fuller lives that includes living in homes of their choice, in their communities, having access to good health care, participating in communities through work, volunteerism, and membership, and enjoying meaningful relationships with families and friends. Our mutual accomplishments have led people we support and their families to enjoy greater independence, have a stronger voice in their support, and more fully participate not only in their communities, but in the way that they receive their services. And that advocacy has led us to where we are today, poised to bring more flexibility and innovation into our system. As community-based supports and services evolved over the past 30 years, and we moved away from institutional-based settings, we have supported more and more people in the community using a person-centered approach, putting the wants and needs of the individual at the forefront of the decision-making process. Now we are challenged to go even further, to provide more flexibility in customizing services, to ensure successful outcomes when helping people meet their individual goals. That's why OPWDD launched Care Coordination Organizations last year as a measured first step in our path to providing a more holistic approach to serving each person. The introduction of Care Coordination Organizations, or CCOs, was the result of considerable outreach with our stakeholders. Throughout this transformation process that we undertook 4 years ago to determine how we could support you better, we heard overwhelmingly that people wanted flexibility and innovation in their services and a lot more choice. The recommendations of the Transformational Panel, which is a group of individuals, family members, providers, and advocates, form the foundation of the change we are seeing today. With CCOs, people have the option to work with their care manager to plan their disability, health, and wellness services, rather than having to work across several agencies to access services. Many people are already experiencing positive results through this process, and we continue to evaluate and refine this service to give everyone a positive experience. Enhanced care coordination was an important and major step, and it forms the basis of managed care, which will ultimately provide flexibility, quality support that can be measured in a form of successful outcomes. Since we launched the CCOs in July of this year, care managers now help plan a person's supports. It's based on the wants, needs, and strengths of each person identified in their individual life and a continuously evolving life plan, which reflects each person's life goals and changing needs. And as we move forward, the creation of each person's life plan will be informed by the individual's Coordinated Assessment System Summary, also known as the CAS. The CAS summary was originally introduced to our system after individuals, families, and providers identified the need for an assessment that includes a conversation with the person receiving services. This assessment will help the care manager confirm information already known about the person and identify the person's needs, strengths, and interests, as informed by the individual and the people that are close to them to provide the most complete picture. A person's life plan includes developmental disability-related supports and other services like medical, dental, and mental health. It is reviewed routinely and updated as needed. Care managers help ensure follow-up on medical appointments, communication between providers, and that your services are in line with the goals that are outlined in your life plan. As we continue to evolve, the introduction of managed care will help drive quality supports in our system, challenging providers to deliver outcomes by helping people achieve their goals. These positive outcomes will come through integrated quality services supported by networks of high-performing providers with the flexibility to meet people's needs. Managed care will also ensure that we will provide quality services well into the future. As the rollout of managed care progresses, there will be additional opportunities for you to learn more and to offer input. So exactly what is managed care? Managed care is a payment system in which the managed care organization receives money, which is then paid to providers of services to make sure all of your needs are met. The managed care organization is responsible for coordinating and providing care, monitoring care quality, and paying for care. It is a way to look at your specific needs or as an individual, determine the best way to support those needs, and ensure that those needs are met to your satisfaction. We believe that managed care will provide you with a more responsive system that is better able to anticipate your changing needs, more choices about who is providing your services, what those services include, and opportunities available in the community that are not disability specific. We'll offer better record keeping and enhanced records for access for people receiving services and their families to encourage active engagement and transparency. Providers that deliver high-quality, innovative services that achieve outcomes for people. And it may be easier to understand how we got here and where we are going to see how managed care will work. Much like our current system, it starts with you, the individual, who's being supported, and your family members are the personal support people. You will choose your managed care organization and your CCO. Your care manager at your CCO will meet with you and your family members and or the people who know you best to discuss and create a life plan. Your care manager will help identify the supports you need. The extent to which your providers help you meet your goals to your satisfaction determines their success achieving your desired outcomes and their payment by the managed care organization for your services. Managed care is not new in the OPWDD system. In fact, we are currently working with providers and operating a fully integrated Advantage for individuals with intellectual and developmental disabilities managed care plan for a limited population. In addition, 25,000 people are receiving health care services through managed care. This experience has helped guide us for our path forward. And here are a few success stories from the people being served. Daniel. Daniel's goal is to be more independent. Daniel enrolled in specialized managed care plan when he moved to New York City after his father passed away. With managed care, Daniel benefited from having a care team that would look out for his total well-being. During the development of his life plan, his care team learned that Daniel needed more money to pay for basic items at home. Daniel and his care team worked with New York City's Human Resource Administration to review Daniel's monthly stipend and discovered that Daniel was entitled to a significant increase in his benefits. His care team also learned that Daniel had a strong desire to get a job. Daniel was soon able to start attending a day half program where he's able to work on skills to help him get a job. Thanks to the comprehensive care management provided by managed care, Daniel is able to live more independently and work toward his goal of getting a job. Next, we have Lindell. Lindell's goal is to get a new wheelchair. When Lindell first enrolled in managed care, he was housebound. He had outgrown his manual wheelchair, and using it caused a great deal of discomfort. He repeated efforts to get a new chair had fallen flat, preventing him from attending day programs for months. One of the first orders of business during Lindell's initial assessment of his care team was to get him a custom wheelchair for his height and weight. And his care team worked with his mother and his primary care physician to fast-track the letter of medical necessity and script, which was needed in order to a custom wheelchair, and soon he was able to go back to his day program. Lindell not only feels better physically, but his mood has improved as well as his mom's. Lindell started receiving home care services for a few hours, which helped Mom's life improve as she was able to run errands and do what she needed to do for her own health. And lastly, we have Judith. Judith's goal was to replace the outdated assistive equipment. Judith is an independent self-advocate who relies on her assistive equipment to maintain her independence and quality of life. Her decision to enroll in managed care was influenced heavily by her desire to get durable medical equipment quickly. Judith's movement and speech are limited, and she uses a motorized wheelchair that she controls with head movements, and a speech device that she operates with her eyes, in addition to other equipment, which include a hospital bed and lift. When Judith enrolled in managed care, her care team learned that her speech device was not working and that several other items were old and did not function well. Her care team, durable medical equipment specialist, and provider network team worked together with the vendor to repair her speech device, as well as order other medical equipment. These items have allowed Judith to focus on her ultimate goal, which is to get a job. The transition to managed care is in itself an evolution which will be carried out in stages. The transition to managed care will occur initially on a voluntary enrollment. In January of 2019, what we call the early adopters will begin providing managed care of only medical and behavioral health needs for people with developmental disabilities. Early adopters are provider-led managed care plans that provide non-OPWDD long-term support services today. and are now going through the application process to become a certified mainstream managed care plan. And you may recognize some of these plans, which include iCircle, Partners Health Plan, and Hospice Choice. In August of 2019, Voluntary Managed Care for Developmental Disability Services, which means that you decide whether you want to enroll in managed care, will begin to be offered in areas of the state where early adopters are approved. These early plans will be made up of OPWDD providers, the dedicated agencies that have worked with individuals and families for years. No sooner than 2021, mandatory managed care for developmental disability services will be implemented, which means everyone is enrolled in managed care to receive OPWDD services will begin to roll out. And before we move to mandatory enrollment, we will make sure that voluntary managed care is providing people with choices and quality outcomes. We will be continually evaluating our progress, and we will make adjustments as needed to ensure a smooth transition. With the development of this specialized managed care approach, people with developmental disabilities will become one of the last populations in New York State eligible to transition to a delivery system that supports greater access to integrated services. And providers will have the opportunity to be reimbursed under a payment system that will support better outcomes for individuals and their families. We've heard the timeline, and now I think what everyone in this room ultimately wants to know is, will I be able to keep my services in managed care? Many of the providers people use today will continue to provide supports and services. We are establishing managed care organizations that will be controlled by one or more nonprofit organizations. Those organizations have extensive experience in coordinating care for people with developmental disabilities and will contract with providers who also have expertise. Managed care will also give you access to other providers that you may not currently be using, including specialists who can help meet your needs. Continuity of care provisions will ensure that your current supports remain in place when you enroll in managed care. And like many major initiatives we undertake, there are going to be challenges along the way. But by working together, we can build a sustainable future of supports for people with developmental disabilities. OPWDD is fully committed to hearing from you and responding to your concerns as we move forward. This is the first of many points of outreach that we plan to do with the people we support and their family members. The concerns we receive will be continuously gathered, and because many are similar, will be included in a frequently asked questions document, which will be regularly updated and available on the OPWDD website. And also, you can always feel free to reach out to our regional offices, or you can email the People First Waiver email to ask questions or share feedback. And so we have questions that were collected from our local advocacy groups from many of the folks that attended or folks that weren't able to attend that forwarded those to us. So we could start with some of those questions, and then we can take some questions from the audience, if that makes sense to folks. So one of the first questions we got, and we had this from many people, is what will the role of the care coordinator under managed care be? And so the care coordinator will continue to help people develop a life plan for all of their developmental disability, medical, and behavioral health needs. Managed care organizations work with the CCOs to connect people to a network of providers that will deliver the services identified in the person's life plan. Managed care organizations will contract with the CCOs to coordinate the person's care, and if a person chooses not to work with the CCOs, the managed care organization may provide the care management for that person. Another question that came out from a few folks was, if we have established relationships with specialists, how are we sure that that's going to continue under managed care? And the managed care organization can offer physicians a single case agreement, which means that the physician can agree to continue to serve you, and the managed care organization will pay the physician. So that question really came in my last forum and came through from a number of people, was that recognizing that we have individuals that have long-standing relationships with specialists for a number of years, and the concern is that they may not be able to continue those relationships to managed care if their physician doesn't want to join the managed care entity. And so that single case agreement is really saying that physician will continue to provide the supports to the individual, and that they can bill the managed care, and managed care will pay them for that. But they don't have to take everybody else under managed care, but their commitment is to their patient. So I just wanted to make sure folks understood that. Lots of folks want to know what happens if I choose not to enroll in managed care. And so enrollment in managed care is voluntary through 2020. And during that time, OPWDD will carefully be monitoring and evaluating the transition. In addition, we'll be meeting with families, individuals, and other stakeholders to provide information and answer questions similar to what we're doing today, and we'll be doing that ongoing. This WebEx is being recorded and will be on the website, and we'll continue to put information on our website. And we'll make sure that you guys have an email address where you can send in your contact information so that you can join our conversation, so you can be up to date on any kind of changes or information, that you'll be able to get that information going forward. Enrollment for everyone receiving supports will occur in 2021 and 2022, and information and guidance will be provided to you throughout this time to assist you in making your selection. And I think it's important to know the commitment from OPWDD about evaluating during this transition time. This is the draft timeline, and if we're thinking things need to slow down through this voluntary enrollment as we're evolving and changing things, that we can slow that timeline now. This is really just a draft timeline, but we will be continuing to evaluate that progress. So I wanted to make sure folks are aware of that. Why don't I stop on some of those questions and see if there's questions in the audience, and then we could take some questions if anybody has sent in any questions from our WebEx, okay? Yeah.
You had private insurance. How will that be affected with managed care?
Sure.
So see the specialist through.
Sure. So the question is that if you have private insurance, how is that affected as you go into managed care? And right now, going into managed care in the beginning of the voluntary, you're not able to join in voluntary through the managed care because we're still working out the private insurance. So that will be coming down the road. So that's not going to be involved in managed care right now. But as we work through that, private insurance will be included. And the way that they're looking at private insurance is that it'll be kind of like a wraparound. So if there's co-pays, the private insurance will be able to help with the co-pays. So that's how it's looking right now, but it's not available when we start with the voluntary enrollment in the beginning of 2019. So stay tuned as that's being developed and worked on. Yes?
So if you've already signed on to the CCO, does that qualify you as already signing into?
So no. So the question is, if you've already signed in with the CCO, does that mean that you've signed in with managed care? Nope. CCO, the Care Coordination Organizations, is separate and distinct from the managed care. So the CCOs is really the care manager role where they help develop the life plan for the individual and identify the supports, and they can help educate you about the managed care as these entities are being developed and which entity that you want to belong to. So the managed care role is really a network of providers that will, when we're fully implemented, will include our disability-specific providers, healthcare providers, behavioral providers, dental services. We'll have a network of providers there that the managed care entity will contract with, that then you can get your supports and services from that. So the CCO is the care manager role, developing the life plan. They're going to help you connect to what services you need through the managed care. Okay. Yeah.
And how does self-direction fit?
Sure. So the question is, how does self-direction fit into this? So self-direction does not change with this. You still have your personal resource allocation. And there will be no changes at this point to self-direction. We don't see any changes with that. And so you'll still have the flexibility and innovation that you have with the same staff that you're using and how you hire. We don't see any changes with that occurring through managed care. Yes. Yep.
Managed care.
So that it will funnel through the managed care, but everything will stay the same within self-direction. There won't be any changes to self-direction. I think there was somebody over here first, and then I'll come back to you guys. Go ahead in the back. so you're asking about the measure of support. How are we going to determine the outcomes are positive and through the managed care? Am I right about that? Okay. So that's a really good question, and it's still one that's under development. So there will be stakeholder groups and involvement of how we're going to develop what those outcomes are, because we don't have those defined yet. So we know that we want to limit unnecessary medical visits or hospitalizations, but we also want to make sure that people go to their medical appointments and get hospitalized when they need them. So that part is still being developed, and we have not defined what those positive outcomes are going to be of how we're going to contract with the managed care on those. So I think as we're going through these forums and getting input, again, make sure that you stay connected to that, join the conversation, make sure you connect to that, because as we're putting information out, we would want to have public input and comments with that, and for you guys to be involved in that process for us as we're developing that. So it's not developed yet, but we know that that's an important, critical piece for us as we're going through managed care.
As managed care, how do you define unnecessary medical visits? I mean, what you just said with that is probably very unsettling to a lot of people in this room who go to a lot of specialists and understand that a lot of times it seems to come down to more or less the bottom dollar than it does the actual quality of care.
Yep. So I can describe it not necessarily as the hospitalization, because I think some folks we have chronic things and need to go to the hospital, and we're not looking for anybody not to go to the hospital when they need to go to the hospital. But I know one example that we had was there was an individual that was living independently, and they had 3 different dermatologists for the same issue, and each dermatologist didn't know the other one existed and was prescribing different medications for that person. So we want to make sure that we don't have duplicative services, and we want to make sure that people are getting the support that they need. So that would be kind of an example of having not the right necessarily support. We would want to have one dermatologist. We want to make sure that that dermatologist is treating the issue and prescribing the right medication and not going to 3 different specialists. That's kind of an example of that. Yeah.
What's the connection with Medicaid and Medicare? Is this all paid for through Medicaid, or how does that work?
So there's to be a contract between OPWDD and the managed care entities, and then anybody that has Medicare or Medicaid, that's the services will be covered under that for billing purposes. Yeah. So and those will be the first folks that are going to be part of able to join the managed care, where private insurance will be down the road a little bit. Oh yes, I'm sorry. The question was about Medicare and Medicaid and how it relates to managed care and being paid. So my apologies. I have to remember we're on WebEx to repeat the question. So I think in the back you had a question. Yeah. Yes.
I'm curious. With Medicaid, now you can be on straight Medicaid, or you can be with Medicare. So how is that going to be folded in, or will NBC, for example, be one of the providers?
Right. So I will say up front, I'm not really familiar with all of the specifics of the insurance and how that's all going to be working. I mean, this is really kind of level setting that we're going into managed care, and we don't have all of those specifics. And there might be policy people that would have better information for you on that. So we'll gather that question, and we'll make sure we get answers back to you for that. So thank you. And, yes.
I'm kind of new to this, so I apologize if it's an odd question. But is managed care essentially, is that like an outsourcing of something the state does today, service?
So the question, oh, sorry, go ahead.
Not-for-profit organization will manage it going forward?
Right. So the question is OPWDD outsourcing the managed care? Are we doing that now? And what that's looking like? Is that basically the question? Yeah. So really the idea of going to managed care is really to make sure that we have some flexibility and innovation in the services and looking at the person in a holistic approach. So right now, if you have to go to behavioral health supports or medical supports or disability services, the families, especially people that live independently, have to navigate that all on their own. And so now that they'll have a care manager under the CCOs, which we implemented in July, that care manager can help develop that life plan and help coordinate those services. The managed care entity will have a network of providers, which include the developmental disability providers, to be able to take a look at the person as a whole and be able to connect those providers to them. You're welcome. Yes.
You indicated, you started your remarks by saying you're jumping into something that you don't understand. And I guess my question is, if you guys don't understand it, how are families and providers going to understand what we're jumping into?
So I don't remember making the comment that I don't understand, so
It was your opening remark, but.
Okay, so there is a pilot of the integrated advantage, I forgot, it's FIDA, I don't know the acronym of that we have as is in downstate. So it's in Westchester, Rockland, the 5 boroughs, and Long Island that's operating now. So that was kind of our test to see how that works. So we do know that. But I think what we're saying is that this is evolving, and we don't have all of the answers right now. And so what we're trying to do is get up in front with folks, because we've heard feedback from families that sometimes we wait too long to share information with the individuals that we serve in families. So we want to make sure that we're coming out in front and saying this is kind of where we are. We want to make sure that we're getting feedback and comments and questions as this is evolving, so we're incorporating that into it, is what I meant. I didn't mean to say that we don't understand where we're going or what we're doing. So my apologies for that. Yeah, sure.
One of the issues that I've noticed throughout the years is there are not enough providers of specialized services, dental, mental health, and so forth. What are you guys planning to do to ensure that the folks who are served by OPWDD actually have providers?
Right. So the question for folks in the WebEx is that currently there's a lack of, or maybe not enough providers, specialist providers to support individuals that we serve, and what are we going to be doing about that? And so, in fact, in our pilot downstate, there was a big concern about behavioral supports, and dental services were really lacking, and I think everybody could probably say that across the state. And going into this, that managed care that's down there, the network of providers they were able to get connected enhanced those services tremendously. And as part of our guidance document, if folks haven't had a chance to look at that, it is on the website. And it's all about developing the network of providers and what we need and the expectations that OPWDD has set forth in developing that network of providers. So that is certainly a concern of ours, is making sure that we have adequate providers for all specialists, and that is what the expectation is. The managed care is to network to develop that. Mary, do you have a question?
What happens to Medicare and Medicaid at the same time?
So if you have Medicare and Medicaid at the same time, that's fine. You're dual. You have dual insurance, then, and that won't be a problem. That goes right in there. Yep, no problem. Yes.
Managed care organizations, how many does OPWDD see available to individuals?
So we just the application process for early adopters is out now. We know that there's at least 3 or 4 entities that are looking to apply to become early adopters. We're not sure how many more are going to be coming down to apply. So again, stay connected, because as we get information that's updated, we'll be sure to share that information with you. Yes.
Could you define entities? I'm unsure of what you mean. Like at one point, the document almost cataloging of service providers, but you're not. It sounds like you're almost like the CCO, like you're developing separate entities and pick and choose.
So, yep, okay, so the question is, what do I mean when I use the term entities? So I said the managed care entities. So there'll be different managed care organizations, and I probably shouldn't use the word entities. I should probably use the term managed care organizations to be consistent. The managed care organizations, there'll be a number of different organizations, and within those organizations, they'll be developing their network of providers that will be providing the services, which whether it's behavioral health, medical, disability-specific services.
So isn't that redundant to what the CCOs are already beginning to do?
So no. So the question is the CCO and the managed Medicare oh my goodness.
Care organizations.
Yes, Medicaid organizations, care organizations, is a duplicate in services. So no, the care coordination organizations are really about having the care manager develop the life plan and identify where the supports are, where the individual's needs are, their strengths, and the supports that are needed, and then connecting them and helping them navigate to get those supports in place. The managed care organizations are the organizations that are going to build that network of supports where the care manager then can help the individual figure out which supports within that managed care organization will provide those services. So the care manager is not providing the services except for developing that life plan. The managed care organization network will be providing those services. Yes.
I think one thing, what if you choose through your DCO, basic services, and I hear you're doing your managed care stuff, what if you're set with your doctors and you don't want to go through your network? What does the person do with that?
So I think, right, so I don't know that there's going to be a choice about whether you can join the managed care or not. I think that the idea is that
it's mandatory up there, so that's why I'm asking, but what if somebody doesn't want that?
Yeah, I'm not sure. Do we have an answer? Do you know that answer? I don't know that I have that answer.
We'll get back to you.
I don't know that I have that answer. My understanding is it's mandatory, but yes, if you have the basic plan, you already have your physicians in place.
Not if you didn't get the information, they don't.
No. So I'm saying for you. So your question was that if you have the basic plan through the CCOs, you have your physicians, you don't want to choose managed care.
Right. What if people don't want to do that?
Right. That's the question. So we'll take that back and get some answers to you for that. Yes, that's good. Yes.
I have a follow-up question for that. Just to follow up on that, what about minor children who have private insurance and their parents? And right now, Medicaid is secondary insurance.
So the private insurance is not able to go through the voluntary at this point. That's still being developed. And what we would envision is that once it gets rolled up, that would be like a wraparound. So if there's co-payments through Medicaid or Medicare or whatever that might be, then that private insurance would help do a wraparound for that.
My concern is similar to Tina's in that, my son, we have a pediatrician that he's seen for his entire life.
Yep.
We have specialists that are out in Boston that we have no problem paying for right now.
Right.
If it's mandatory for him to join us, are we going to lose those?
So the single case agreement that I spoke about a little bit earlier would apply to that. So if you have a specialist that your son's been seeing for a number of years and you want him to continue to see them, then you can do a single case agreement between the managed care entity and that physician. The physician would still get reimbursed at the same amount that they're getting reimbursed. That wouldn't change. And then there's not a commitment for that physician to have to see everybody else within the network. It's a commitment that they'll continue to serve your son. Okay? Sure.
How does managed care get paid?
So they'll have a contract with the state of New York, and that's how they'll get paid. And then it will be based, so and the providers will get paid based on the outcomes that they're delivering. So right now, our providers are paid for, so I keep forgetting to repeat the question, so my apologies to folks on the WebEx. The question was, how does the managed care organizations get paid? And so the managed care organizations have a contract with the state of New York. The managed care organizations contract with the providers. Today, providers are paid based on a unit of service and the time that they deliver that service. But we don't really have a way to measure the quality of that service that they delivered. Are we happy with the quality and the outcome of that service? And so this shift is to really make sure that we're paying for the quality of outcomes that we're looking for, which we still need to develop and define what that's going to look like. So that's
okay. So you've got another layer of payment.
So we have the contract with the managed care, and then the managed care will pay their providers based on their outcomes.
So you're paying care coordinators, now you're paying another layer of managed. So their job is to keep the money down. So they are going to say yes or no to services.
So their job is not to keep the money down. Their job is to make sure that their providers are providing the quality outcomes that are identified in the individual's life goals and in the life plan.
Because I've worked with managed care before.
So the question is, I work with managed care before, and the concern is about decreasing of payments and services. So and I think what's important is that the managed care that we're developing, that OPWDD is committed to, is that it's provider-led organizations that are agencies that have been providing disability-specific services for a number of years, is designed differently than the mainstream managed care. So the idea is that this is long-term support, that we know that people will need their disability supports for their lifetime, if for some. And we want to make sure that instead of paying by unit and by time that we're paying by outcomes. That's what we're looking for. So we want to make sure that we have high-performing providers that are delivering and helping people achieve their life goals.
Outcome piece.
Yep.
Have to develop.
That's right. So we have to develop that still. Yes. Yep. That's true. Yeah. Hold on one second. We have folks over here that haven't had a chance to ask questions yet. And I think you're over here. You have a question too, correct?
Yes.
Okay.
It sounds like to me there's removal added between me and freedom of choice that I started for. So it feels like.
It feels like, I'm sorry?
The removal added between myself and the freedom of choice I'm looking for. Another layer of bureaucracy between freedom of choice.
So it seems like another layer of bureaucracy and choice. Is that?
Between freedom of choice, yeah.
Taking away his freedom of choice.
Yes. So, right, so that's not the intention of this. I mean, we still have the care manager that's going to be working to help develop that life plan. The expectation is that the managed care organizations would have a network of providers, so you can choose from either the different managed care organizations or the providers that were in that network. So there should be hopefully more choice than less choice. Yeah.
But what happens when you have a care manager who doesn't seem to know much?
Right. So the question is, what happens if you have a care manager that doesn't seem to know much? And so we know that the care managers are new to their role in training, and so I would say that if you have concerns, we should be connecting with the regional offices, and we can help you with that. But we would expect that the care manager, the difference between the Medicaid service coordinator was that that individual kind of worked independently, and the idea of the care manager is that they work with a team, and they should have a level of support and network to be able to support you. So if you're feeling that that care manager isn't to the standards of what it is that you need, then we need to be able to connect, and we can connect with the CCOs and work with you on that. So we can take your name if you're having issues. We can help you with that. Yes.
I want to go back to what you were saying just a few minutes ago. You were saying that right now there's no way to evaluate how well the agencies are providing services for people, and there's no measurement there. And one of the reasons you're going into managed care is to get that measurement and then pay for, I guess the payment would be towards each goal, correct?
Yes.
I guess when I hear you say that, well, I can think of it as putting parts towards work. You don't have any idea how you're going to do that, but yet at this point you're telling us that it's going to be done.
Right.
And so I'm really having a hard time understanding what you're doing because it doesn't make sense to me when you're putting parts towards work.
Okay. So the question is, if we're moving from a unit-based system that we're currently in where we pay for the unit, we pay for the time, to a system where we're paying for outcomes, that seems like we're putting the cart before the horse in terms of, because we don't have the outcomes outlined yet, right? So I know that, so we're looking at the value, what's called value-based payment of care is what it's called, going into the managed care organizations. And it's really, and you're right, so we don't have the definitions exactly of what those outcomes are going to look like. And so we could take that feedback back. I don't know that I really have a specific answer for you for that. I'll come back to you. I think you have a question over here. I saw your hand up before. I don't know if you still had a question.
So, I guess, related to some of the discussion that's going on here, I hope that there'll be very meaningful and ongoing and deep involvement by consumers and families in defining what equals value in the system. Because I think sometimes the rubrics that government uses are a little bit different than those that families use. And, I appreciate the overall effort, which is like we might be able to do better with the same resources that we have now, or even save money in some areas so we can do the things that everybody's looking for that we can't currently get. But I think it will be really important to keep everybody, really everybody involved and open-minded about what that looks like. Because, and then I think, what's the monitoring system going forward? Because, the plan's accountability is really, where this is going to work or not work. How are you going to hold them accountable? I think would be important.
Yeah. Thank you.
So when you look at setting, so if you go to value-based and you're not going to do unit rates and costs, you're going to look at some sort of case rate type of equation?
Right. So there'll be a set price for each of the managed care organizations, right. And then when you have providers that are demonstrating whatever the outcomes are going to be, there'll be incentives for them to demonstrate that they are meeting the individual's life goals. That's the.
And will those amounts be
determined kind of in the same way that people's PRAs are determined now based on their needs, or it will be more of an average across a certain population, and they'll be working within that.
There's a formula.
Yeah.
I could not even begin to describe what that formula will be for them to be set at what that rate is going to be for the managed care organizations. And then there'll be incentives within this managed care organizations for those providers who are the high performing, meeting the needs and the outcomes for the people that we serve.
And they'll have the flexibility to determine what rates they pay, say, someone's physician.
They're going to have contracts with everyone, yeah.
Right, so that we won't have the problem of, like, if people are forced to use Medicaid providers, we have that problem now where there are so few of them because the rates are different than what they get paid by the commercial plan. So hopefully,
you'll have a broader base of providers, correct?
With that being paid, I mean, you know, some of us are experiencing the problem of services not being available because the rates aren't adequate. So I'll use Pathways to Employment, for example. Try to find Pathways program around here because people can't afford to deliver it. So we need to just make sure that the math works for everybody.
Right. And I would just say to folks that we know that there's challenges within our current system. We are not in this, you know, world where we think that managed care is going to fix everything. We know that, but we think that it's the next step in evolution for our service delivery system, and it is important for us to hear your comments and your thoughts and your questions as this is evolving and developing. So I think that that's important, and to your point is, making sure that we stay connected, and I'll just say again, join the conversation, but we'll continue to make sure folks when signed in, hopefully you've shared your email address so you can get the local information as well as the information from central office.
Just a comment piggybacking on training. I am a parent of a child. Well, I can't say a child, he's now 32 years old. And they work in the field. Basic training needs to take place with staff. Staff are dropping names of the clients that they're working with. That is a problem. As a parent, I wonder how often is my son's name dropped out there in the community?
Right.
That is a huge issue, and now it's getting bigger. And I'm really concerned about that.
Right.
I really think basic training needs to happen with staff across the board because when I have confronted these people, it's because there's confidentiality.
Right.
They're like, well, you need to know their names. No, I don't.
No.
So I really think we need to bring it back to the basics with training with staff because to them it's just a name.
Yeah.
And these are our families.
Yep. So folks out into WebEx, the comment was really to make sure that the staff are being trained and bringing that back to the basics of training. And the example that was used was confidentiality, making sure that staff understand their responsibility of holding information confidential and shouldn't be sharing names out to individuals that have no need to know their name or what their diagnosis or needs or any of that kind of stuff is. And that's just one example of some of the training that's needed in the field. But overall, some basic 101 training to the field is definitely needed, is the comment, right? Hold on a second. Yes?
Yeah, I had a question. Regarding the CCOs, as this rolls out, is there going to be choice in the event that the CCO isn't doing their job and there's some dissatisfaction, whether it relates to competence or fraud and theft, whatever it is, and the person wants to change to a CCO, is there a contract period that they're going to have for that? It's going to be at any time they can change and pick the 3 or so that are within the designated area.
So the question for folks in WebEx is that if you're with a CCO and a care manager and you're not satisfied with the service that you're getting, are you under a contract or can you change, and is there availability to change? So the answer to that is there's not a contract, that you can certainly, you can either go to the CCO and ask for a different care manager. You can change CCOs if you're not satisfied with the CCO. We're very fortunate in regions where we have a number of different CCOs that are operating within our regions, so you can change.
What's the policy on that? You're saying you can ask for the CCO. There's a difference between asking, demanding, saying we're doing this versus asking the CCO.
So I use the term ask, but certainly you can make
Okay.
I don't want to say you can force it, but your choice is that if you're not happy with that care manager, you can make that change. And do that. And you can make the change either through you just want a different care manager or you want to go to a different CCO, and that's fine. Yeah.
I'm struggling still to understand outcomes. And being that you have essentially a pilot going on in a huge chunk of New York, what kind of outcomes are there?
Yeah, I don't have the specifics of that. I don't know if anybody on the panel does, but we can get that out to you. I don't know that I have those specifics of what those outcomes are, but there are outcomes that have been developed for that pilot, and we can get that for you. Yep.
Any examples?
I don't have those examples. Do you have any examples of those?
Well, the 3 people you mentioned were the ones with
yeah, but I don't know if those.
Plan.
Yeah. So the question is, what were the specific outcomes that are in the pilot to develop? Folks are struggling with us not having defined what those outcomes are going to be as we move forward to value-based plans. So the 3 examples is what you're suggesting. But so, you know, we just want to, and I don't know that those, there's different levels of outcomes, right? There's the individual outcomes. So, you know, Daniel wants to make sure that he can get a job, and, you know, how are we going to about getting that? And then there's the different level of, from a provider perspective is, you know, are you meeting all of your goals and objectives, which I think is where the struggle is, right? We know when we meet an individual's goals, but are we meeting it as a system? And that's the part that we need to get back to you on. I don't know that I have the specifics for that. So, yeah. Yes?
I'm just getting very confused. The managed care, this program you have now, is this covering, like, for self-direction, where they have units of hours to figure out how many staffing is, does that cover that?
So self-direction, the question is self-direction, how does that fit into managed care? So self-direction, you have a personal resource allocation that you'll continue to have through managed care, and there's no changes with that. So you could still hire your staff, you could still have those outcomes with that. I think the broader question is that how is a network of providers defining what those outcomes are? That's where the...
No, it's not. That's not. The question is basically what it comes down to. I'm a family member, I'm a DSP, I'm a support worker, got it all. So I'm trying to figure out the budgeting of it, how you budget, because we budget in order of hours for staffing and stuff. If you're not going to do that, there's outcomes, so how are we setting up stuff like that?
So there's no change to self-direction. So how you're doing it now is how you're going to do it under managed care. There's no changes to self-direction.
Okay.
How is OPWDD going to measure the CCO's outcomes? Is there a measurement for the CCO outcomes? How are they evaluating whether the CCOs are doing what they are intended to do?
Right. So there's the oversight entity of OPWDD that would oversee that piece of that, and I don't have the specific. There's a contract between the state of New York and the CCOs, and it's outlined in there. I don't have the specifics here that I want to rattle off and say something wrong to you, but that it is on our website. We can put that in our frequently asked questions so you have the specifics around that. Mary, did you have something?
I did. And it's on the development of the outcome. I worry with a child whose outcomes are probably going to be incremental over the course of his life because he has significant needs and very significant limitations, that no provider is going to want to take him on if those outcomes are not tailored to the complexity of our kids. And I'm not hearing anything about that. And
so that's a good point. So some folks are kind of where they are, and that's really good for them. And we want to keep them stable, and we don't want to have any regression. And some folks will have some regression, no fault to the provider. So that all has to be incorporated in what our definition of quality outcomes is going to be. So yes, that's a very good point, and it is something that we're aware of and will consider. But yeah, good. Do you have a question?
Yes, I was wondering what was the name of the New York agency that heads this up in the entire state of New York? In other words, where does the actual money come from that pays you to pay the other?
Department of Health. The question was, who's the entity?
Department of Health.
Department of Health, yeah.
Where is where are they located? What's their home address? Department of Health for the entire state.
Yeah.
Is it in New York City?
So I think it's up here. I think it's up here. I don't know the specifics. I think it's in Albany.
Just the Department of Health.
Department of Health, yep.
And that's where all the.
So if you go on our website or the Department of Health website, you can see the guidance document that's out now in terms of managed care organizations, and it should have all of the information of the Department of Health there for you.
I have been under the impression that there's such a shortage of workers and that they can't provide the services because of the shortage. I have 2 disabled sons, 2 boys. They've been disabled since they were young.
Sure.
And now they've gotten their ages 21 and 23. And for the past, for sure 3 years, but past 5 years, my wife left 3 years ago, but she was running all this, and she seemed to be able to get services. But for the past 3 years, I've been, every 6 months we do an IEP. It gets tweaked, but only from my input, because we haven't been getting any services at all.
Right.
But right on the top of the booklet, when they're done with all the paperwork, they give you a thing on how to refuse services. Well, how can you refuse something you're not receiving?
Right.
So how is that measured in terms of outcomes?
Right.
I mean, are they getting paid for providing services to my family, but not providing it as long as they can create the paperwork? And one of my big concerns, because I'm retired out of the military, I'm a veteran, I deal with the Department of Defense, which is a little bigger organization than New York State.
Yeah.
And I've learned over the time that some terms, waivers, are meant to take things away from people, not give things. You know, and because of that fact, I'm concerned that we're just throwing some more buffers in there. You know, more buffers so you can't trace where the money's going and who's getting it.
Okay.
And that makes it really difficult, especially when you don't understand, when the people doing it are not knowledgeable of what's going on there.
Right.
You know, your organization can be being used just like another organization who can believe in something, but, you know, it's not tangible.
There was a lot
That's
in that.
a big concern.
Right. There was a lot in that to try to summarize for the WebEx. So we'll start off with the shortage of staff, because that's really what you're experiencing.
Well,
is
they're
the shortage
using
of staff.
that. I can't believe that they can't find somebody.
Well, it is true. That is definitely an issue that's across the state where there's a challenge of getting direct support professionals. There's a commitment from our governor that increased the salary for our direct support professionals. We're developing career paths for our direct support professionals, but it's definitely a challenge, and it's one of the things that I said that we know there's challenges in our system today that managed care is not going to fix, you know, everything, and that's certainly something that we're well aware of. That's a challenge. If you're not getting the services, I do want you to connect to our regional office, because if that provider's not able to provide you services, there might be another provider that can help you with that. We want to connect you to that.
I've been
We want to help.
providing out of my own funds my services for my most severe.
Right. So we want to take your name and number, though. We want to connect with you on an individual basis about that, for sure.
And I've been told that possibly to offset my costs.
Right.
They can't provide the service I'm providing it.
Right.
Well, that I could find an individual and they would pay the individual, or they would reimburse me.
Right. So Jackie, our staff, is going to take your name and information so we can connect with you on that.
Thank you.
And then the other, I think, broader topic is the Department of Health and how do we make sure that we're not being duped and it's costing us more money and all that. I think we're going to take that to our leadership and let that group answer that question for us. So we've captured that.
How do we evaluate?
And how do we evaluate?
Those are doing it, and they're saying, okay, I put in the paperwork. How can you evaluate
Right.
if they're doing a job?
Thank you. Yes.
Doing the paperwork?
So the question, the other part of that piece was that if providers are doing the paperwork and saying, you know, you're refusing services or they're not able to provide the services, are they getting paid based on outcomes, but they haven't developed that service? So we need to capture that. Thank you. Appreciate that. I knew there was a lot, and I couldn't keep it all. Thank you. Yeah.
I'd like to add to the shortage of staff, because I receive services where some of our services are just thin.
Yeah.
And I'm really not getting enough support that I need. I'm not getting the visits. I'm only being taken like grocery shopping, and that's about it. Anything else I've had to do on my own.
Okay.
But
so we're going to have Nicole take your name, and we'll help you with that on the side. So Nicole, if you could describe your name and telephone number, we can follow up specifically on that for sure, because we definitely want to be able to help where we can.
There is a real shortage of staff. I just spent 6 weeks with my daughter.
Yep.
With no staff. I've taken her to work. I've given her her work. And I don't see, you know, I don't see a lot of effort going into finding a way that providers can find and
include. Right. So the concern for folks in the WebEx is really there's a lack of direct support professionals and the impact that it's having on families being able to be that caregiver for the individuals, and what are providers doing and OPWDD doing to help with that effort. Yes.
You mentioned earlier about quality outcomes. Who determines what is the outcome is quality or not?
Right. So we haven't defined that yet. That's what we're going to be doing as in the next few months, and we'll be including and having forums like this to gather that information and develop that. So we have not defined that yet, but it is something that's important for us to define. And again, you know, this is a forum that we really just kind of wanted to level set on managed care, the direction that we're going. We know there's still lots of questions that we don't have the answers to, but it was important to us because we've heard from individuals that we serve and their families that we're not getting out early enough to share information. So it does put us in a position where we're standing here and not necessarily having the answers that you guys want, but we're committed to getting those answers and to having the conversations with you guys as we're developing this. So just, you know, we do appreciate the feedback, and I apologize I don't have the answers, but it's kind of the process that we're going through. We want to make sure that we're inclusive rather than exclusive. Yes?
Do you have anybody that's helping you develop this that has a disability living in the system, and are they involved in this?
Yeah, so I'll start back with the commissioner created the transformational panel that kind of set this path for us for managed care. There were individuals, there were self-advocates, there were advocates, there were providers and families that sat on that transformational panel.
But are they still involved?
Yes, yes. And so our self-advocates across the state have been involved. They have shared lots of questions and comments and concerns, and absolutely are involved and will continue to be involved and absolutely have a voice. Yeah. Yeah.
I'm sorry, I missed the beginning, but is housing a part of the mix? Will managed care be working on that as well?
So yes.
Okay.
Yep.
That's great.
So the question is about housing, and is managed care going to help with that? So yes. Yes.
Accountability, which is part of this. My son had OPW services for a long time. Initially, I used to be able to get a report from a community care person taking out what they did and that kind of thing. And then I'm sure it was mostly to reduce the amount of staff time. I never got those reports back anymore. So in terms of, my son could tell me some of what they did, but was helpful for his development. The other thing is, there should be ways of having accountability beyond what the person says they did. And then the other thing is the life plan. I know there are people that don't. I think the assumption too often is that somebody is at a level and they're not going to develop or advance or evolve anymore. So when you talk about a life plan and whether those goals are met, that should be an ongoing process so that it's, so they meet one goal and then you hope that things are going to improve and continue.
So for folks in the web, it's about accountability and making sure not only are the agencies being held accountable, but accountability for all of the services that are being delivered. And then the second part of that is, how am I going to paraphrase that? Is the and I just lost the last piece.
Continued development of the
life plan goals. So in that piece, I just wanted to address in terms of life plan goals because as we talk about people achieving goals, and I think to Marianne's point before is that some of the goals might be that they stay where they are. That might be an okay goal. Right. That's an okay goal. That's okay. Other folks have the capability to, make it to that next step, and that's good for them. But everybody's goals will be different, and they should be different within the plan.
So it's an ongoing process.
Ongoing, absolutely. And I think the accountability piece to that is that we still have our division of quality improvement that's going to be overseeing our agencies and our providers and doing that. But if you have something that's specific that you're looking for your provider to share progress for your son or daughter for that, I think you should have that conversation with the organization. If you need help from the regional office, we're here to help you with that as well. Okay? Yes.
I have an outside question, but
yes.
I don't know if you can address it. How does this compare maybe nationally with the trend? States like Massachusetts or California that have progressed as well. How are they providing sort of the trend?
Yeah. So the trend is about, you know, with the other states that are progressing and are progressive states, and how do we fit within that. So some states have moved toward the managed care. I think what we've learned, and we've had lots of conversations with different states, and we can get you the states that we've connected with on that, because I don't know off the top of my head, but I do know that what we're doing differently is making sure that our disability providers are at the forefront of really helping us develop this, because it's so important that we don't have a managed care, mainstream managed care who knows nothing about disability services come in and provide those services without our providers who know how to develop those services and how to deliver those services. So I think what we've done is try to take the things that are working well in some of the systems and also find out where the pitfalls were and try to fix those in our system. But we can get that for you. I know there's folks at the central office that have that information, and we can put that on for us. Sure. Yes.
I wonder if you could speak a little bit about the measurements of success or outcomes for the managed care organization. How will they be? How will we determine if they're being successful?
Right. So the guidance document is out right now on the website. I think it's really just the preliminary of how to apply to become a managed care entity, and that's really about their network of providers, how they're going to develop that, what the expectations are of who they're going to have on staff, which is a medical director, behavioral, that kind of stuff with that. And I don't know that if it's defined specifically yet about what their outcomes are going to be. I think that's going to be the broader conversation of, you know, what do we expect of the managed care organizations, what can those managed care organizations expect of the providers, that will all kind of go back up to what our expectations and what we kind of define as we're going through this. All right, let's turn to WebEx and see if there's any questions from the WebEx that haven't been asked yet in this group, because this is really good questions. Thank you all.
Will home health aid services be effective?
I don't think home health aid. Yeah, so the question is, will home health aid services be effective? No, I think, you know, when we have the continuity of care, it's really making sure that the services that you have in place will continue as we go through this transition to managed care, so that should not change.
Is there a list of managed care providers that would be available to choose from?
So will there be a list of managed care providers that will be a list to choose from? And so, yes, so we're in the early stages of managed care organizations putting in their applications to become early adopters. There will continue to be an application process for others that will not be early adopters. That information will all be posted on the OPWDD website. And again, I don't know if there's a thing here that says, join the conversation. Please make sure you join the conversation, because that's we're pushing information out to folks, so we want to make sure folks have that information. So yes.
Can a single provider agreement be entered into even if the doctor is a provider in a different managed care network?
So yes, so the question is, if there is a doctor that's being used or a physician that's being used and it's in a different managed care organization, could you have a single case agreement with that? Yes, that's the idea of the single case agreement, is that we want to make sure that we have valued relationships that our individuals have with their specialists, a way to continue to have that relationship through the managed care without having a commitment to the managed care. It's a commitment to the individual person. So yes.
For people with private medical insurance, Medicare and Medicaid, COB usually works this way. Private insurance is primary,
right?
Medicare secondary, and Medicaid pays lastly.
Yeah.
So how does this impact developmental disability services, related services that are not covered by private insurance?
So it's the same thing, so that there's no change with that. So as I indicated earlier, that the early adopters were not able to do private insurance, so you wouldn't be able to enroll at this point in voluntary managed care until we've worked out the specifics about the private insurance. And just because there's so many different private insurances, that's what is more detailed around that. But it would be the same structure: private insurance, Medicare, Medicaid. That's the order of payers, and that would be the same in managed care.
If the managed care organization is the network of providers, then what happens to the CCO's current network of providers?
So the CCOs are the care managers, right? So those care managers would still be in existence and the CCOs are separate entity from the managed care organization. So the there's two separate things. You have the care manager who's responsible for developing the life plan and connecting and educating folks about the managed care organization. The managed care organization's network of providers are the ones that are actually going to be delivering the services either through their network, whether it's the medical, the behavioral health, or the disability down the road. Did you have a question in the room? Yes.
Yeah, I was wondering if your doctor is not in the group and you want to ask them to have this single
case agreement.
First of all, is it a long application process? Is it going to be off-putting? And do any of the doctors, do they have to follow up when they're in managed care either by default or because they choose to do this single case agreement? Are they going to be required to send in reports after they see the person after every visit, or quarterly, or what's the administrative burden on a doctor that they wouldn't have, let's say, now?
Right. So the question is, if you have a specialist or a physician that you're using that's not connected to a managed care organization and you want to continue to use them, what's the administrative burden on that physician, and is it going to be a deterrent for them to want to fill out maybe a lengthy application or reporting to the managed care where they don't have that administrative burden now? Is that right? And I'd like to tell you that I have those specific details. I do not, but I would imagine that the idea behind having a single case agreement is that we want to encourage relationships between the individuals that get the services and their physicians. So I would think we should not be having any lengthy. It should be a simple case agreement between the physician and the managed care entity. I would imagine that would be something that we would be looking for. And I don't know that they would have to do a report, but we can get that specific for you. And understand that we don't want to have an administrative burden where our physicians are then not wanting to do single case agreements. It would be completely opposite of what we're trying to accomplish. Yeah. Yes.
Kind of going along with that, what is the incentive to bring clinicians and physicians on board to be part of your managed care network? If there's a shortage right now, especially of real quality physicians and providers, how are you going to make it an enticing, opportunity for them, especially if they're having to be measured about what their services are?
Right. So the question is, how will the managed care organizations entice providers to join their network of service providers, really? And, right, that's basically your question, right? So, I think what we see is the OPWDD serves over 130,000 individuals that see multiple physicians or have disability services. And so in order to capture those individuals, that's how they're going to have to get connected to a managed care organization. So each managed care organization, you can go through that guidance document as to how they're going to, their responsibility is in their application is to respond to how they're going to build that network. So I can't answer because that will be their responsibility to do that. But all of that document is on the website, and then once those applications come in, it'll be described of how they plan to build their network. Any other questions from Martha?
Someone is asking you to explain what you mean by wraparound services.
Right. So I use the term wraparound for private pay insurance. And so in managed care, and again, we're not into the private insurance yet. That's down the road. But what will happen is sometimes people have co-pays, and that private insurance will be able to cover the cost of the co-pays. And that's what I mean by the wraparound for that.
Is there going to be another meeting next year?
Yes, we'll definitely have more forums for sure. I think we're going to try to do them at different times and in different locations so that we can make sure that we're inclusive. Again, join the conversation. Is there any other questions? Yes.
I have one more question relating to the managed care and the rates that are paid. What are they going to be in comparison to private insurance companies like Blue Cross Blue Shield or MVP and so on? And I mean, do we have the same problem that we're going to have going down the road as the managed care organizations negotiate contracts with New York State?
Right.
What are those rates going to be, and how is that going to how is the state going to address the issue of getting providers and attracting providers when the rates are likely going to be much lower than what private insurance pays?
So I'm not sure that we know that for sure, that it's going to be lower than what private insurance pays. So we'll take your question. I don't have the answer, but I just wouldn't want to assume that. So the question is, how do we know what the rates are going to be for the insurance?
We can also assume that.
And then there's the assumption is, will it be less than what the private insurance companies are paying? And so can we get an answer back to folks for that? So I don't want to assume. So. Anybody else? Question? Yes.
Yeah, I had an opportunity to speak with a provider in the mental health system who has gone through the managed care process, and they spoke about the fact that it was really a mess entering into it for the first 3 to 5 years.
Okay.
What steps is OPWDD taking to ensure that that's not the case? Entering into this, because it's brand new.
Yes, yes.
There will be quirks, and we understand that.
Yes. So the question is, mental health has transitioned into managed care, and there was, it was a mess or growing pains.
I was going to use that word, I chose not to.
Oh, you didn't use the word? That's what I heard. So the question is, you know, what's OPWD going to do to try to not go down the same course as mental health has done that? And I think that that's really what is built into the system, is that this is a draft timeline. We're evaluating it. We're starting off as voluntary. So we started off with the pilot. Then we're going to start off with the voluntary. We're going to assess to see how that goes. If there's not choices, if there's not where we want it to be, we'll slow things down. We're going to build. There's going to be pauses in there if we need to. So we're not going to rush through this. We want to make sure it's as smooth as possible. Is that going to be perfect? No. There's going to be barriers, obstacles? Yes. Are we committed to work with them? Yes. Are we committed to our families and the individuals we serve to hear what those are and try to figure them out? Yes. Yes.
Are there folks who have been part of the pilot project who could be or would be available to do some kind of a session like this?
Oh, that's a good idea. We could ask that. I think that's a great idea. And we just gave examples of folks, that stories that they were willing to share that we shared, but I think that's a great question to ask to see if we could do that. I think that would be great. We will definitely put that down and ask.
I wasn't so much necessarily thinking that individual.
No, I know what you mean. Yep. Okay. Yeah, the broader. Yep. I think that's great. I like that. Anything else?
What will be the advantage of voluntary enrollment?
So what's the advantage of voluntary enrollment? It's really, you know, I think it's up to the individual. I mean, I think that we gave some examples that if folks are struggling and having difficulty now, that this is an avenue to try and explore and to see if that's able to meet their needs. So I think that would be an advantage to have a network of team working around you to kind of work across the systems to get you the supports that you need. So I think everybody's going to be on an individual basis of whether it's valuable to them or not. Anything else?
What happens when a family's in crisis? Do managed care, CCOs, or does everybody work together to help us get this thing together, and what would be the next thing?
Yeah, so that's right. So, I mean, the idea of the care coordination organization and the care manager is to have a team to support that individual. Yes, they would connect with the managed care if needed to. Regional office is always here available as well. So pick up the phone if you're having a problem in crisis, connect with us. And do you have a comment? I'm sorry.
It doesn't work.
What doesn't work?
Calling.
Our regional office? All right, so we're going to connect with you on that, because that's not okay, because we should be helping you with that. So.
And I appreciate it. I don't mean to sit here and say that, but I can't sit here and just say it's great that our families are getting the help. So that's why I had to sit here and say we need to be able to pick up the phone and call and know that there's help on the other end.
Yeah.
We have families in crisis.
We have
just us.
Yeah, no, that's right. So, and we have our START system, which is
that's the problem.
So, okay, so we can connect. We'll get the names of folks for that, because if that's not working for folks, we want to know that. I mean, I think that's important. We need to know what's working and what's not working. And if we don't know what's not working, we can't help you. So that's important. So thank you. Yes.
Sorry to be take up so much airspace. One of the areas that I have experienced the most difficulty is in getting the mental health system to work in concert with the development disabilities world. I'm pleased that they're already sort of working along the line of managed care, but this integration is very broken, and it leaves folks who have both mental health and a developmental disability in terrible crises, and things just don't work. So I'd really like to know how that is going to be addressed.
Right, so the question is the folks that have mental health and developmental disability and are in crisis, it's very challenging in the system today, and how is that going to be different going into the system in the future? And again, I'll just say that it's not a magic wand. Things are going to happen. Relationships need to develop. But part of going into the managed care and into this waiver world is to be able to cross those services and have that care manager help with you to navigate through all of those systems and connect. And is it going to be bumpy? Probably for a little bit, but that's the intention, is to have better support to serve the person in a holistic way of meeting all of their needs. And so right now, OPWDD focuses on the developmental disability portion of that individual, and mental health is the mental health, and those systems don't really work well together. The idea of the holistic approach is to make sure all of those services are surrounding that individual of what they need. And so that is the intent for that.
It's a wonderful intent.
Yes.
However, the critical piece is those care coordinators need to have a lot of education.
Yeah. 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 Yep.
In order to even have a clue of what the services are.
Right. Absolutely. Absolutely. Agree.
They're supposed to be doing that now, and they're not.
Right.
So why all of a sudden we created this new system? Why is that going to work now when it's not working? Why is that going to work tomorrow when it's not working now?
Right. So I think things are right. So the question is, if care managers are supposed to be doing that now, why isn't it working now? And I think we have to recognize that care managers have been in their role for 6 months. It's new, and they have MSCs that have transitioned and stuff. So I definitely agree that there needs to be lots of training around individuals. There needs to be a better connection to that. I don't think there's a magic wand to say that, when we go into managed care, all of it's going to be fixed. I think it's an evolution of making sure that people understand what the resources are. The idea of the care coordination organizations is that it's not just the care manager that's doing that. They have staff that are on their, as part of their care coordination organizations that they should be tapping into. And if that's not happening, then that's an issue, and we need to take that back to our care coordination organizations, because that should be happening.
But that's what MSCs, I'm going to go back.
Yep.
That's what they should have been doing before. They should have been offering all this information to them. They hadn't done it for years and years and years. Why all of a sudden do we think the new CCO is going to?
So the question is that the MSC's responsibility over the past year should have been connecting to these services, and the MSC should have been aware of what those services were in the field. And I think we had MSCs that were good at that and MSCs that were not good at that. And why do we expect that the CCOs now are all of a sudden going to be able to provide this? And, part of the reason of transitioning from the MSC world into the CCO was that there was the feeling that the MSC was kind of out there on their own, connecting with the individuals and knew what the services were that they were aware of. The idea of the care manager is that they have a team of support that's supposed to be behind them. They might not know everything themselves, but they should be connecting back to their team within the CCO to find out what else is out there in the community. So if that's not happening, though, we need to talk and understand specifically what that is. Yeah. Yes.
So if the care coordinators have a team, does that mean they're sharing information with everyone on the team and nobody sits on it? If I didn't sign off on it?
So no, so then their team is to support them as the care manager to support you. So there's only to help provide services to make sure that they understand what services are out there that are needed for you specifically. So no, that's not breaking HIPAA.
I don't get it.
So they're talking about the services you need, and they're talking about you.
They're talking about, so the care manager has a caseload of individuals that they serve, and somebody might need, let's do something with the mental health or dental services, and they don't know what resource that's available within there. They can go back to their team and say they have an individual that's on their caseload that needs X, Y, and Z. What else is out in the community that we can do? And that's the network of support to support the individual.
You're 100% sure they're not using names or?
Well, I don't know that I'm 100% sure that every single person's not doing that. So, but, you know, I think that goes back to your point of making sure that people are HIPAA compliant and making sure that they're confidential in the information that they're sharing. And I think that we understand that. Yes. Yes. Yes.
I was late, so I apologize for my other brought up. Did you talk about assistive technology at all in this presentation or any questions around that? My understanding is that that's not going to be covered through the waiver. Is that accurate?
I don't know that assistive technology is not going to be covered under the waiver. Do you know that? I haven't heard that, so we'll take that back. I don't know that I have the specifics for that. Yeah. Yeah.
So I guess, again, I'm concerned as a parent of several children with disabilities and as a professional in the field.
Sure.
You have to fix this that we're doing now first before we add on another layer.
Yeah.
So this isn't working right now. So we need help with these CCOs. We need your energy into the CCOs before we move on to something else.
So I'm not sure that that's an accurate. So the question is, if the CCOs aren't working now, how are we taking on more, and our efforts should be into the CCOs? I'm not sure that as a system the CCOs are not working. I think that things are need to be fixed for sure. There's lots of energy around the CCOs for issues that we have. We're meeting with CCOs regularly. So it's not that we're not addressing those things, but I wouldn't necessarily say that the system of CCOs is not working. I think that there's definitely been an improvement in supports to individuals. Can it improve? Yes. Are we working on that? Yes. And I hear your point of, you know, maybe we should get that solid before, but I think, again, that, you know, we're not flipping the switch on managed care. We have the pilot. We're going to go into voluntary. We're going to pause if we need to pause. So I don't want people to think we're full force ahead, and regardless of all the feedback that we're getting, that this is the deadline. That's not the race to the end. It's evaluating and finding out what's working and what's not working, and how do we fix that.
But I hear mandatory in 1 year.
Well, you hear mandatory in the draft timeline of going from 21 to 22, not in a year, and from 21 to 22. And I've said throughout that that's a draft timeline. And if we need to hit the pause button because we need to work on things or slow things down, that's a commitment from OPWDD, that we're evaluating it through the process, and we'll make adjustments as we need to. Yeah.
I think one of the things that OPWDD can do is, right now, the care coordinators view themselves as MSC. That's what they were forever. So that's what they are now, and they've changed the title, and we've got different things going on. But I think that OPWDD needs to really define what the differences are clearly, and provide lots of support and training to the care coordination organizations so that they're really getting up to speed on what it is they're supposed to be doing.
Right.
Because right now, that's not the case.
Right.
I can tell you that for sure.
So we have feedback, just for folks in the WebEx, is that MSCs have transitioned to care managers, but they may not have transitioned into what the role of what a care manager expectations are, and that OPWDD could do a better job, or the CCOs can do a better job in making sure that care managers understand the distinction between what an MSC was and really what the expectations of the care manager are. I do know that when we were going through this transition, OPWDD did a number of trainings, not only for the care coordination organizations as they were developing, but also for the Medicaid service coordinators. But I hear you, and I
will say that they set through that.
Yeah, but we continually to do it. That's right. Okay, good feedback. Thank you. Yes.
Also, I do have to comment on this gentleman. I'm a parent and I'm also a support broker. And I go into a lot of meetings as a support broker, and every manager or your coordinator, they go to meetings and they say, we have no idea what we're supposed to do.
Okay,
that's we don't understand a life plan, we don't understand the IAM assessment, they fill with their computers, they're not working, it is, they don't have access to it.
The life plan is the ISP.
I've been at one rotation.
I got you. Okay. So I think I hear you loud and clear. I hear you. We'll connect back with our care coordination organizations. If there's specific things that we can do for specific individuals, we could take names and follow up specifically on individuals, but we could certainly bring them back the feedback to our leadership team that's meeting weekly, if not more frequently, with the care coordination organizations on the feedback that we're hearing. So I think that's important. Thank you. Yes.
This past September, just a couple months ago, my care coordinator got the bomb on me and told me I'm in tier 4 of care coordination. I have yet to figure out why I'm in tier 4. You cannot answer the question. There's no answer to the question.
Okay. So look, we can talk to you separately like that. I don't think we want to do that in this forum, but we can talk separately with you on that. No, I understand the point. Yeah. Okay. I got you. Okay. Joan? Yes.
And I also understand there's a transition period.
Yes.
And I can live with that a little bit, but.
Yeah, no, I hear you. I think that point's very valid, so thank you.
We have 2 questions from the WebEx.
Yes.
What happens if a care manager asks for a service from a managed care company and the managed care company says no?
Right, so the question is if a care manager is asking for a service from a managed care organization, the managed care organization says no. There's a grievance process that can be used. The grievance process hasn't changed at all from what it is now. Going forward, there's still, the chain of command that you can go through making those requests and grieving that if you're not satisfied up to a fair hearing. So.
And the second one is, when will regulations or OPWDD guidance be available for providers who serve individuals who choose to enroll in managed care? And that policy document is under development. It'll be released very soon.
Okay, thank you. Oh, sorry. So the question was, when will there be guidance document from OPWDD to the provider organizations? And that document is being developed now, so it should be out shortly. We don't have a timeline for that. That was, I think, a provider's on the WebEx asking that. All right, so we lost about half of our audience here, and it might be because it's the middle of the afternoon. So thank you all so much for coming. Thank you, everybody at the WebEx, for participating. Again, join the conversation. If there are questions that you have that you weren't able to ask, please email them to us and make connection with the regional office, and have a great afternoon.